Welcome, everyone. This is the GammaTile Insights Elevate Your Knowledge webinar series that we are offering every third Thursday of the month. My name is Corey Thomas, and I'm from GT Medical. We're a company that has created and distributed GammaTile. We're excited to have you join us for this insightful webinar where we will delve into the cutting-edge advancements of GammaTile therapy. And today we have the honor of hosting Dr. Simon Hanft, who is a leading expert in the field and will be presenting on building a successful GammaTile program. So a little bit more about Dr. Hanft. He is a renowned neurosurgeon specializing in the treatment of brain tumors and complex neurosurgical conditions. With extensive experience in both clinical practice and research, Dr. Hanft has made significant contributions to the advancement of neurosurgical oncology. He's a board-certified neurosurgeon specializing in the care of brain tumors and tumors involving spinal cord. He is the section chief of Neurosurgical Oncology for the Westchester Medical Center Health Network in Valhalla, New York. Dr. Hanft's expertise lies in the development and implementation of innovative therapies for brain tumor treatment, including the use of GammaTile. His commitment to improving patient outcomes through cutting-edge technology and personalized care has earned him recognition as a leader in his field. In this webinar session, Dr. Hanft will share his valuable insights on building a successful GammaTile program, and he'll cover key aspects such as the fundamentals of GammaTile, best practices for implementing a GammaTile program, and then a few case studies and real-world applications of GammaTile. Whether you're a seasoned professional or new to GammaTile, this webinar promises to enhance your understanding and equip you with practical knowledge to advance your practice. If you have any questions, please feel to type them into the chat area or wait until the end where we'll open it up to those if you have questions. So thank you for joining us again. And without further ado, let's welcome Dr. Simon Hanft. Thank you, Dr. Hanft.
Corey, thanks so much. And to the GammaTile people who put this together, I appreciate the platform here. This is, I think, a good opportunity to go over a lot of the lessons that I've learned when it's come to the act of bringing GammaTile into my institution, and how we've had some success with that here, some of the hurdles that we faced. We really try to give a practical take on what's involved in launching GammaTile in your respective institution. So we do have some clinical applications and clinical discussions here, but it is, if you will, kind of a little bit more of an administrative kind of talk in some ways. So again, appreciate the introduction, and I'm going to share my screen now, and hopefully that looks good. Corey, you can see that okay?
Yep, looks good.
Great. So we decided to just go over quickly in what GammaTile is before I launch into how to maybe get into your own success in terms of implementing it. So GammaTile is a form of brachytherapy. Brachytherapy is the local application of radiation to a surgical site in a controlled, directed fashion. What makes GammaTile unique compared to other forms of brachytherapy that have been used for brain tumors in the past are a few features which you can appreciate here. The first, and for me, this was very much an appealing aspect of the technology, is this resorbable collagen square, or this tile that you see, which in many ways simulates the feel of gel foam, which is quite familiar to neurosurgeons. It's part and parcel of how we obtain hemostasis, basically, in any cranial tumor operation. So that kind of drew my eye initially when I was looking at the implant. And what is also unique to the technology is how these seeds, and you can see them through the tile here, you can see this purplish strip here that contains 4 seeds total. And the way the seeds are offset from the edge of the tile is important in terms of how the radiation is delivered. And also, it was an ingenious way of having having the seeds inserted into this tile so that they're at regular intervals. And that provides for a very specific type of conformal dosimetry, which is a little bit beyond my understanding as a neurosurgeon, but provides for a fairly regular distribution of the radiation to your resection cavity. And there's also quite a bit of, shall we say, it remains static within that cavity. So there's not a lot of shift, there's not a lot of falling out. It behaves as kind of a lining along the resection cavity due to some of these features that you're seeing. And so again, this was really the draw for me, the physical appearance and design of the product, I thought made a lot of sense. Some of these things I just mentioned, but this is a bioresorbable, conformable, 3D, of course, collagen tile implant. This structural offset is what's referred to as the distance between the surface of the GammaTile along the brain surface and where the actual seeds are situated, such that by the time the radiation actually hits the brain surface, there's a little bit of an offset there, so that the highest dose of radiation is not right up against the brain surface itself. And this is designed in a way to allow this type of radiation, this dose, this 60 gray dose, which is a hot dose, to get to a depth of approximately 5 millimeters. The other important aspect of GammaTile is the short half-life. Now that's of course related to the cesium-131, which is the active radiation source in these seeds, and is not new to GammaTile. Cesium-131 has been utilized in brain brachytherapy in the past, but that is one of the advantages, is that half-life is short. And so a significant, nearly all of the dose has been delivered within 4 to 6 weeks of administration of the GammaTile. So hopefully those two slides provide a little bit of a background regarding the physiology of the tiles. So forgive me for the slides here are a bit wordy, but it's a instructive type of talk, if you will. It's less, at the end I get into a case presentation that helps to that really helps to exemplify some of the principles here. But for the most part, this talk is designed to help give you a sense of what I went through, and to hopefully draw upon some of those lessons and apply them to your own institution, with the understanding that every institution is going to have its own hurdles and its own unique pathways to getting this technology in place. So I start in this slide by discussing the important players and the important themes when it comes to building a GammaTile program. So when you're going about this, and I'm sure there are a few different people participating in the talk today, but when you go about this, there needs to be really an identifiable champion of the technology at your institution. And obviously for me and my institution, that was me as a neurosurgeon, but that can be a radiation oncologist at other institutions. It could potentially be even someone in the oncology sphere, though that is less common for obvious reasons. But you really need to identify a champion. And if you're listening to this and you're interested in the technology, you are going to be that champion. But that's a key concept, that there's someone who's got to really be willing to take this from the beginning to the finish line. That you can't really rely on other entities to carry this through, that it's really got to be you or someone that you work closely with who's got to be passionate about this technology. And the critical partner, if you are a neurosurgeon, which is typically the port of entry for this, is radiation oncology. And what I note here, I think is true. I think it holds water, which is that if either side is less than enthusiastic, it's going to be a difficult road. That doesn't mean that if a radiation oncologist at your institution has not demonstrated an immediate embrace of GammaTile, that the mission is over. on the contrary, it requires sometimes a little bit of work on your part if you're the neurosurgeon. I'm speaking to the neurosurgeons here to explain and to show to the radiation oncologist the value of this technology. Even if that occurs and there's still trepidation, that's a different story. But you are going to be bringing this into an institution that almost certainly is completely naive to the benefits of the technology. And so it's incumbent upon you to emphasize the strong side, the strong suit, and what the particular advantage of this technology is to your partner in this, and that is radiation oncology. And then, as the case with GammaTile is a case with probably almost any type of novel technology that you're looking to bring into your institution. You're going to have to get the chairs of your departments behind this. You're going to have to get administrators behind this. These are obvious concepts, but that's the road that you're looking at. And as I noted before, some institutions are going to have different hurdles than others. And those are things that you're going to almost certainly have some familiarity with. And if you don't, GammaTile, as I found in my own institution, because I brought it in fairly early on in my tenure here, it's a great test case for figuring out how to get things like it into your institution. So now, starting with the clinical justification, I like to talk about what was specific to my plate here, if you will, and why I gravitated towards GammaTile. Before we get into why ultimately it worked here. So the two major reasons at my medical center, Westchester Medical Center, that I was pushing the technology. First and foremost, I definitely began to believe that there were certain clinical circumstances where I felt that this represented a superior option to traditional external beam radiation, whether that was in the re-irradiation sphere, whether or not that was just re-irradiation along the lines of IMRT, or more specifically, when it came to re-irradiating with SRS. I felt that there were certain circumstances where GammaTile seemed like it might present a superior clinical option for patients, and I'll get into some of those specifics. And secondly, perhaps a little bit more even to the point, is I started realizing within my first few months of starting here that I was losing patients who were coming from a big distance. Now, again, this may not be relevant to every institution, but many institutions have a fairly large catchment, which is definitely the case here at Westchester, a catchment that extends over 100, almost to 150 miles north, not so much south. If you have any sense of the geography, there's obviously a lot of congestion. We're just north of Manhattan and the Bronx. But as you get north of here, we have a significant footprint. And we were getting patients transferred in with acute presentations from metastatic disease in particular, we were having a very hard time bringing back in to my hospital for the radiosurgery to the resection cavity following surgery. And so I didn't even know what was happening with these patients on some occasions. Either the patients were not even getting radiated, or they were getting whole brain. I mean, there were some archaic things happening. And so after I recognized this problem, I felt GammaTile represented an excellent solution for patients specifically with upfront metastases. Okay, and again, we'll talk about that specifically later in the case example that I have. But I'll get back to this theme. Beyond those clinical justifications, there were also what I classify here as personal justifications that I think represent major benefits or boosts to bring something like GammaTile into your institution. So it is a program, if you will. I know that's a vague term that gets thrown around, but there is a multidisciplinary effort that has to accompany GammaTile. So it's neurosurgery, it's radiation oncology, it's obviously physics within radiation oncology, but there are other elements to that equation too, including your operating room, your radiation safety people, even your extenders and other staff within the hospital, there are relationships created out of this. And as is the case with any type of new technology, there's a buzz associated with that. And that wasn't necessarily what I had in mind when bringing this in right away. I really do think that I was kind of more clinically motivated, but I started realizing that these were kind of unforeseen benefits to bringing this in, that there was enthusiasm about this and questions about this. And I saw a real uptick in eagerness among multiple clinicians within the institution. Also, I think it's very important to note that innovations like this can excite, as I was just saying, can excite people within your department, outside the department, and really within hospital leadership. Hospital leadership is often looking to tout technological advances that are being made within service lines, within departments. And I can tell you that even as recently as a month ago, and I've had this technology here for over 2 years, that we filmed an internal, beyond other marketing that's gone on, we filmed an internal video for the board. So that's among multiple things, but the reason I just mentioned that is not only the recency of it, but the fact that there's been sustained interest in what's going on with GammaTile and these patients here. Also, the halo effect, I won't kind of belabor that point. That's, I think, associated with any type of new technology, but we have had multiple examples of patients who will either be reaching out directly or even through the company, because they'll have researched and then read about GammaTile, and they'll be interested in getting it. And even if they're not a candidate, they may end up having a procedure with you or end up in your institution for that reason. So it is a type of access point for certain patients. I also want to emphasize a clinical trial portfolio. And I think that this is particularly compelling for some younger neurosurgeons like myself out there, that when you bring GammaTile into your institution, it opens doors to clinical trials, even as simple as the GammaTile, the START registry, which technically qualifies as a clinical trial. And so it's something to kind of hang your hat on a little bit. When you enroll any patient who gets GammaTile, you can enroll them in the registry. And I have to say, I created quite a bit of momentum with that. And in many ways, I give GammaTile, the START registry in particular, a lot of credit for some of the success that I've experienced over the last year or two in getting involved in some other national clinical trials, because it basically set the tone for myself and the department. It gave us some experience in bringing something like this in, getting it through our IRB. And so it was a very nice foundation piece for us. And then there are other clinical trials which we're involved with, run by GammaTile as well. So this not only helps in terms of providing options for patients clinically, but there's also a downstream financial impact for the hospital that I have to, in a way, it's kind of embarrassing to admit, I was essentially clueless about when I started here at Westchester Medical Center. I was already 6 years into my career. I was just so clinically focused on doing surgery, as I think many of us are. But as I've gotten into this technology and others, I've realized that there are other aspects of the job, if you will. And I think that this presented a very nice transition into thinking along those lines and finding other ways to kind of spread my wings, if you will. So those are some of the important points regarding my initial adoption of the technology. Now, what are the barriers to this? And I tried to highlight here some of the key things that either I've encountered or I was fortunate enough not to encounter, but have heard. So I would say the first and foremost, what I and others hear the most is that GammaTile will cannibalize the SRS volume, right? That is an argument that we hear on many occasions, and I think probably the biggest deterrent in terms of bringing GammaTile into your institution. So let me say for a second, kind of what does this mean? The concern is that what is typically done for metastasis, large symptomatic, what have you, is that when you decide that metastasis requires surgical removal, You are then scheduling that patient 2 to 3 weeks following that operation for adjuvant stereotactic radiosurgery. That has become standard of care. And that is become standard of care because it reduces the likelihood of local recurrence of the metastasis from maybe 30 to 40% without the radiosurgery down to maybe 10% or less. So that is a significant enough impact, obviously, that SRS has become standardized. So there has been an accompanying, not just for metastases, obviously we use SRS for many pathologies, there's been an accompanying major shift to bring these sophisticated SRS platforms into institutions that are big financial drivers. And so the last thing radiation oncology or even you as neurosurgery want is a product that may cut into the volume of patients that are going for SRS. Okay, so that's where that argument comes into play. So then this is the question I have here: how do you combat this perception and in some cases reality? Because there is truth to this. It's not, it's not mythological. So there are a few important points here. So one is you will be using GammaTile in patients that would never return for SRS. Now that was the case for me on multiple occasions. So there is definitely an uptick or it increases your capture in those situations because there are patients who are not going to come back for their SRS. Now, every institution is different. If you're at one of the elite cancer centers where people are going to trip over themselves and do whatever it takes to come back to your institution, regardless of the logistical nightmare it may present, then this argument is not going to be significant for you. But if you're at other institutions like myself, which may not have the same name brand recognition in the cancer sphere, and so it may not be the draw for patients to come back and get radiation, or they may go to a facility not necessarily even closer, but that has what they perceive as a superior machine. You may not have that patient coming back to you. You are going to be aware of the uniqueness of your geography and the challenges that are present in that geography. But I can tell you from my experience, for me, and I do think it's fairly widely applicable, that we were having patients, as I mentioned before, who were not coming back for the SRS. And so this is definitely one way of capturing those patients. Now, secondly, there are often patients that we are still doing surgery on who have multiple metastases. Okay, so that is, that there's still obviously a role for that. When there's a large dominant metastasis causing symptoms, newly diagnosed, there's a role for surgery in many of those cases. So there are specific clinical situations where you may be using GammaTile in a patient with multiple metastases in the surgical site, but the other smaller metastases or asymptomatic metastases can still be targeted. Let me pull that back. Can still be targeted with SRS. So all of a sudden, GammaTile and SRS becomes a complementary moment. It's not always GammaTile versus SRS, but as I've noted here, the equation can be GammaTile plus SRS. Also, as I've noted here, in fact, if the non-surgical mets are far enough from the resection cavity, you can get patients in for SRS treatment quickly. So that prescribed 2 to 3 week wait after your surgery has been historically adhered to in order to allow for wound healing before you are putting external beam radiation through that incisional site. But if your incisional site is at a distance from where the metastasis requiring SRS is located, you do not have to wait for those 2 to 3 weeks. So that is a shorter time to treatment for those other metastases. And as I'll talk about again, you're not having to navigate the demanding logistics of repeating an MRI, getting that authorized, and you have to do that MRI the overwhelming majority of the time because there are changes to the cavity, oftentimes fairly dramatic changes. And this bypasses that process. So I believe that it is admittedly a subset of these patients who are going to get surgery for one met with GammaTile and SRS to the rest, but it's perhaps a little bit more common than you think. And for me, this has represented something of a paradigm shift. And that is the case that I talk about at the end here. So other barriers regarding personnel, these are some important thoughts to consider. You may find that not everyone is on board with GammaTile at your institution. So getting to radiation oncology. Radiation oncology has to be a major ally. This is really a shared experience. But they may have hesitations, and what are those hesitations? Well, there has to be a brachytherapy license in your institution. I was fortunate enough that the radiation oncologists who had worked here for decades had a significant interest in brachytherapy, so that was already in place. That may not be the place at your institution, though I think more often than not, it is in place. But even if it is in place, you may have a radiation oncologist who's not particularly comfortable with brachytherapy. They may not want to be inside the operating room. They may think that being in the operating room is taking them away from seeing patients, and that is taking them away from potential revenue. And just the actual, what I put in quotes here, on call, because there is, as you know, when you're doing any type of operation, some level of uncertainty to how long the surgery will go or when the radiation oncologist is going to be summoned to deliver the GammaTile to the operating room. And that randomness, which necessitates some level of flexibility, might be off-putting to the radiation oncologist. And there are a lot of, there are multiple counter arguments to this, which is what I'll deliver here, but we could circle back to as well, which is that it's a much quicker process than I think most radiation oncologists realize. And I'm not saying this in a negative way. It almost rises to the level of just being a courier for the GammaTile in a lot of circumstances. Radiation oncologists and the physicists have to make sure, for safety purposes, that it is delivered to the operating room and that the process is overseen. But the actual delivery of the GammaTile into the surgical site is done very quickly. The radiation oncologist is typically, and there's varying degrees of involvement, overseeing that process, making sure that the tile is handled properly and labeled properly. But it is not, at the end of the day, a major time investment, even from call to the radiation oncologist and then delivery and then leaving the operating room is probably in total 20 to 30 minutes. So it can be very easily accommodated, but of course it could be disruptive in certain circumstances. We acknowledge that, but it should not be viewed as a multi-hour investment on the side of the radiation oncologist. Now, some physicists also may have their own caveats. That's less common. We have encountered that at a couple of institutions, and that's something that's a little bit beyond what I talk about here, but it's just another potential level of opposition that you may encounter. Regarding OR staff and nursing, we had a fairly permissive atmosphere at Westchester Medical Center, which was positive. That may or may not be the case at your institution. But I think a lot of that depends on, as I noted here in that second bullet point, spending time educating these personnel in these areas. So letting them know what's going on, reassuring them, especially when it comes to nursing, which we've had to on multiple occasions. We've done it either with myself, radiation oncology, or radiation safety, kind of what the risk may be of exposure. We've had questions, understandably, of that nature. We've also had to get into the logistics of who's, as I was just mentioning, who's delivering the GammaTile, who's overseeing it. So these are things that the GammaTile people in particular are very expert at greasing the skids, if you will, when it comes to you bringing this into your institution. So I wouldn't view this as a major burden for you as the neurosurgeon, because the GammaTile people have brought this into dozens of institutions and are very aware of these kinds of hurdles and the teaching that has to be done. But I'm just kind of being comprehensive here in this talk about some of the things that should be at least on your radar. And then another thing I touch upon in this talk, and I will tell you that if there's more interest among the people here listening to this in the economics of GammaTile, I'm not really the go-to person. I would say that there's a white paper that the GammaTile people could provide to you that gets into some of the economics of this in more detail. And there's some offline conversations that can be had. It's not that it's any type of dirty, dark secret. It's just not something that I personally have a lot of expertise in, so I hesitate to delve much deeper than this. But the question often, understandably, is what are the economics of this? And you as a neurosurgeon or the radiation oncologist, how cognizant should you be of the economics? And should this in any way be impacting your decision making? And I don't want this to turn into such an ethical quandary, but the economics for the most part are overwhelmingly favorable for this. But I would also, when it comes to your initial cases and your initial patient selection, of course, you're interested in making this a success. So I would be hesitant about a case that would warrant a massive amount of tile implantation in someone who is uninsured or who has Medicaid. I mean, I think that is something that you have to consider very closely in your early encounters with the technology. I will tell you that I've, in a wonderful way, I really have to say at my institution, I have not really had significant pressure put on me for either over or underutilizing this technology. And I do think that economic analysis has been performed as a technology. I've been utilizing GammaTile now in roughly 40 patients over the last 2 years. And it is favorable, and the company can get into that with you. But I just want these thoughts to at least be in your head, because for the most part, your early selection and the early cases could end up having, whether it's right or wrong, more attention brought to them. And so you want to be, of course, clinically selective, but you also probably early on should be a little bit more aware than you may normally are about the situation, the economic situation of those first few cases. And that's, again, coming from me. So regarding patient selection, how do you make this successful? And we're going to really hone in here clinically, starting with this question: who is a candidate? So these are the general clinical considerations, and by no means are these absolute, but I think as you're starting, this is a more of a recipe for success than some other circumstances. And if there are questions, either me or other people who've used the technology are more than happy to weigh in on the case. And GammaTile provides wonderful clinical support from Dave Brockman in particular, and other neurosurgeons who work closely with the company. So clinical considerations: a solitary MET is one of the more optimal situations, surgically accessible, large, which may seem a little bit paradoxical. I'll talk about that a little bit more. Index are clearly recurrent. Obviously cannot be radiation necrosis, because fundamentally GammaTile is radiation. So you don't want to be superimposing more radiation on a patient who may have or has radiation necrosis. So I've emphasized here, choose your first few patients carefully. Logistical considerations that help drive the decision for GammaTile. Patients coming from a long distance that may get external beam locally. I've said it a few times, that was a big driver for me here. Patients who may have reliability or other types of issues that may interfere with their ability to return for SRS, beyond just the logistics of a long distance. So that is also another consideration. You could always make the argument, well, if the patient's not going to reliably follow up for SRS and take their care by the horns and do the right thing for themselves, why should I kind of reward that behavior? But, we're not in the business of making those ethical decisions, right? We're trying to put these patients in the best possible position to defeat their disease. And there are circumstances where these patients, for reasons that are out of their control, can't access your institution or can't get to the SRS the way that they need to. And GammaTile is a wonderful stand-in for those situations. So for me, again, these are some other points I make here. I like the potential for increased efficacy. That's a statement that I will stand behind, and the clear convenience for upfront metastases, especially large ones. Why large? Because initially, when you're thinking about this technology, at least I did, I thought, well, I was a little hesitant about using it in the larger mets. We're just conditioned to use radiation, and it just seems like extra work, or can it actually be effective in these larger mets? Well, the literature that is published on GammaTile is supportive for the larger mets, and I think a lot of that has to do with this comment that I have here. The cavities for these larger mets can be very challenging to contour for SRS. They often require more than one fraction. And because of the challenges in that contouring, the patients are less likely to get the conformal radiation that GammaTile provides. So perhaps they're getting excess radiation. Perhaps they're more likely to develop radiation necrosis. We don't know this for sure. I don't want that to be the point. But there are definitely some hurdles. Anyone who knows dealing with some of these amorphous cavities to treating them with external beam radiation. I also have discussed multiple mets, doing surgery for the dominant met with the GammaTile, and then doing SRS in rapid fashion to the other non-surgical mets. And I have found that in recurrent glioblastoma, where repeat radiation can be a tricky endeavor, to say the least, that I have used this in lieu of repeat radiation. Because we know it's a bit of a black box when it comes to how we treat recurrent glioblastoma in the first place. And then if we're actually putting those patients through repeat surgery, re-irradiating, based on what the final pathology shows, obviously, and how the patient does, that can sometimes be a tricky proposition. And at minimum, for the increased risk of that patient developing radiation necrosis, I have found GammaTile to be a beautiful way of dealing with patients in that circumstance. In fact, I have a recurrent glioblastoma case on the schedule for tomorrow using GammaTile. I have a slide here dedicated to some workflow considerations. For those of you who just want a little bit of a window into how it works here, it's pretty simplistic. It almost feels like it doesn't warrant this discussion, but my inpatient workflow is utilized really for the majority of my GammaTile patients have been inpatients. As I mentioned before, I don't have a robust cancer center here. I have patients who are coming in acutely symptomatic, and I am using it most frequently in the upfront metastasis moment. And so for those patients, and I think probably most people out there would attest to the fact that we're seeing more and more patients come through our ERs and transfer centers with these kinds of conditions. And over the years, at least for me, I've seen fewer of these patients walking into the office. So once a patient is identified, very basic, I have a group email thread with all the key people, including my treating radiation oncologist. I have the chair of radiation oncology, that's by his own demand, wants to be involved, the chief physicist, the GammaTile rep, and the relevant OR people. Now, it may seem a little burdensome or a little bit out of your scope as a neurosurgeon to do that, but I found it to be simple. I'm the point person, it's organized, and I like the way the workflow unfolds with me sending out that email. This email ensures that an immediate radiation oncology consult is performed, which is essential. And then on the heels of that, a very early order placed for the GammaTiles. And I will provide my own estimate of how many tiles should be ordered for this case. And then radiation can do their own calculation, which we don't get into here in this talk. And there can be a little bit of a back and forth. But this way, we can sometimes identify and have a patient consented and ordered for GammaTiles within a couple of hours. The outpatient workflow is much more slow paced. My patient with a recurrent GBM tomorrow is coming in on an outpatient basis. We identified this a few weeks ago. It's a much easier process because if I haven't emphasized enough, GammaTile requires a few days of preparation because every order is patient specific. The GammaTiles are standardized, but the number of tiles that you're going to utilize is different. So every patient requires a specific number and a specific order, and there's at minimum a 48-hour turnaround to that, and there's some changes to that as well. And the GammaTile people can talk to this audience as well about that, or individuals offline about that process. But the outpatient process is very simplistic. Just one more slide about this discussion, and then I'll get to the case and we'll open it up for questions. So I've had a lot of people ask me, because we've had quite a bit of success in terms of having patients not only consent for GammaTile, but also for the Rhodes clinical phase 3 clinical trial, which is looking at radiosurgery versus GammaTile. So what are some aspects of the GammaTile experience that I discuss with patients? So I think, and this is probably in order of what's most compelling to the patient. I think most compelling for patients is the idea of being done with surgery and radiation in one single step. Now, keep in mind, most patients are probably even shocked that they need an operation. So there's a lot being kind of levied on these patients in one moment here. But and I think most neurosurgeons are going to be as comprehensive in my initial discussion with the patient about what we're doing with this tumor as possible. The surgery being one step, the adjuvant radiation being the second step. And of course, I don't get too into the details of the chemo or immunotherapy that's in their immediate future, but I also touch upon that. But I do think that patients feel very motivated by the idea of having surgery and radiation at once, just getting it done, and that's that. There is also the avoidance of issues associated with external beam radiation, hair loss, which can be very distressing for patients, returning for yet another MRI. I think we underrate how problematic that is for patients. And the concept of coming back just for the radiation itself, as I've said on multiple occasions here, especially from a distance, very onerous for people. Now, clinically, I don't talk about this probably enough in this talk. This is more for the clinical benefit of GammaTile, but the immediacy of that treatment. I think that that really should be emphasized significantly for anyone who's thinking about bringing this technology in. Because we know what often begins as a 2 to 3 week wait following your operation for SRS will drag out until 4 to 6 weeks on many occasions, especially if you don't have a machine in place, a workflow in place processing many of these patients. So the fact that you are starting radiation at the time of surgery is very compelling, and there is early evidence to suggest a lower incidence of recurrence in those patients, or a longer time to recurrence. The conformal nature of this treatment, which I was just mentioning on the prior slide, not having to deal with these amorphous cavities and bigger fields of radiation, you're able to provide a targeted conformal radiation delivery with the GammaTile lining the cavity. What are some of the patient barriers or the hangups that patients have? There's not a whole lot. I boiled it down to, I think, these two. Some patients don't love the idea of the seeds staying there. So I think it's important to emphasize the size of these seeds. They're small. They're about the tip of your pinky. I think that helps to de-escalate the anxiety there. I emphasize how the radiation is basically over 90% released at around 4 weeks, and that the material surrounding the seeds is absorbed into the brain over time, into the brain matter. That usually calms whatever anxiety might be there about the seeds being in place. I also should probably list here that I mentioned it's MRI compatible. Of course, we're getting MRIs immediately after surgery, and it doesn't set off metal detectors. But those are kinds of the conversations I'll have when I put in cranial hardware for all patients too. They'll often ask that. There is sometimes a concern from patients about limited proximity to other people, especially children. Now, if you're very literal about it and read the label, it can be off-putting for patients. But the reality is, at least in my interpretation of it, as long as family, children aren't around the patient in close proximity for a significant period of time, at least more than 15 to 30 minutes and probably hours, I think basically all interactions are probably within the realm of acceptability. Your radiation oncologist may think a little bit differently, and that discussion is really theirs to have. But the way I've discussed with patients, I said basically for the month after the surgery, I would not sleep next to their spouse. That's basically my caveat. That's what I boiled it down to, because that's obviously where you're lying next to someone for 6, 8 hours, whatever the case may be. I want to get into the case example here and then open it up to questions. And this case was specifically chosen to highlight some of the themes that I've mentioned in this talk. So this is a patient with a newly diagnosed melanoma met, 67-year-old with rapidly progressive left-sided weakness and a very distant history of melanoma, something like 10, 12 years. So he presents with this MRI, well, with the symptoms, and then an MRI was done. You could see a large 5-centimeter met, and then an adjacent smaller met of approximately 2 centimeters. In addition, well, I kind of leave it for the end here, but this was an obvious surgical situation. We were able to remove these 2 mets through the same craniotomy, just a different corticectomy, and I lined both cavities with GammaTile. So the only other met that this patient had was this contralateral met. So how did we handle the contralateral met in this case? So there was no need to delay SRS because it's distant from the incision. Could wait a few days for the final pathology just to make sure exactly what this is before you treat with the SRS. You can consider waiting for the molecular profiling and immunotherapy. That option is obviously available to you, and you may consider, given that this is a small met and maybe it's BRAF mutated, that you may end up opting for immunotherapy in this case because it's melanoma. But if I tell you it's non-small cell lung and there's no PDL, there's insignificant PDL1 receptor expression, meaning that immuno is less likely to be successful, then you're more likely to do SRS in this situation. But the point I'm trying to make is that you don't have to wait the full 2 to 3 weeks to treat this, that you could wait a few days. If you really want to see the molecular profile, that could be a little bit of a longer wait. Would you do SRS on that admission? We know that SRS on an inpatient basis cannot be billed the same way it can on an outpatient basis, so that often is poo-pooed at most institutions. It's done in select circumstances. In this particular case, the patient had residual left-sided weakness. He was a candidate for acute rehab. He did acute rehab in our institution, and he was transported for single-shot SRS for that melanoma met during the rehab stay. So this is a change for me, and I think a change for most people. This is someone who I think in the old paradigm would have had surgery still the way I did it, but would have had SRS to the resection cavity and to this smaller met in the customary delayed fashion of 2 to 3 weeks at best. And during those 2 to 3 weeks, how much interval progression would have occurred at the surgical site, we don't know. Maybe minimal, maybe meaningful, but we know there is a subset of patients who have fairly rapid progression. This is a 4-month MRI, post-surgical peripheral enhancement. The contralateral lesion is smaller. This is a 7-month MRI, stable with that little peripheral enhancement. The contralateral met stable to even smaller. Patient remains functionally independent, good systemic control as of April 2024. He has since moved out of state. He's joined every New Yorker and moving out of New York into Florida. That's how long the survival we're getting. We're just contributing to the mass exodus of New Yorkers. And he's getting married. Actually, I think he may have gotten married in mid-June. And he's supposed to get another MRI at some point in the near future if he hasn't already. And I'm looking forward to updating the talk with that new MRI. Now, I want to just, before I end the talk here, this patient has gotten immunotherapy, he's BRAF mutated. I know that there are other factors here that could have contributed to the lack of local progression. But there's no arguing with how nice that image looks 7 months for metastatic melanoma of a 5 centimeters and an adjacent lesion. The MRI looks very clean, and I have multiple case examples that have impressed me, and that is why my enthusiasm remains significant for the technology, because I am seeing beautiful control, clean cavities, in some cases 2 years from the index operation. And so again, my confidence in the technology remains high because of my personal experience. This case was chosen partly for that, but also partly for how we handled that contralateral met and were able to do SRS in the same patient who underwent GammaTile. Again, this is not an exception. I don't want to say it's the rule, but there's definitely some commonality to this. So hopefully the talk touched upon some of the themes that we wanted to emphasize here in terms of how to build a practice. And also I hope you developed a little bit of a sense of how we apply it clinically. So with that, Corey, I'm happy to open it up. I don't know if anyone had any specific questions or if the chat has any questions or if you guys have anything you want me to elaborate on, but happy to go further than that. Thanks again.
That was fantastic, Dr. Hanft. Thank you so much. And if you do have a question, you can raise your hand on the lower bar of the webinar, and then I will open up the channel for you to ask your question. We do have we have two questions actually. This one is, what is your experience with primary glioblastoma and dose?
In the recurrent setting, is that, I imagine that's probably what the question is.
No, it's what is your experience with primary glioblastoma and dose?
Yeah, I guess what they're saying, yeah. So personally, I have not used GammaTile in the upfront setting. Index glioblastoma, I have not utilized it. So if that's what the question's getting at, I don't have a great answer for that.
Yeah.
I could tell you that I think maybe where that question is heading is it's a little bit trickier to deliver the IMRT when you've put GammaTile in place. That it's not the standardized dose delivery that you may be used to. Now, beyond that, I can't get into the details because it's really a radiation oncology thing. That's not been that has been one of the reasons I haven't used it up front in glioblastoma. Of course, theoretically, the concept of using GammaTile and not having to do IMRT in glioblastoma is an incredible notion. We're not close to that. Even Gestalt, which is the acronym for the trial that GammaTile has in looking at GammaTile plus IMRT or just IMRT, GammaTile in that case is still being looked at as a boost. And I think it will show an advantage, and mainly because of the immediacy of it. The idea of using brachytherapy in place of IMRT is incredibly compelling because of how onerous the 6 weeks of IMRT is, but that's not being looked at for this technology. So the impact on the dose is that there is an impact on how the IMRT is delivered, but it's hard for me to get into those technical details.
Another question, Dr. Hanft, is with 40 patients implanted, what is your anecdotal long-term experience with the use of GammaTile?
Yeah. Well, yeah, I was getting to that a little bit at the end here. It's overall very favorable. I've seen so we are talking anecdotally. I have multiple patients, including the one I just showed, who have had enormous symptomatic metastases, and I've just used GammaTile only. And that itself is a little bit of a step for people who are so used to using SRS. So you almost feel a little bit naked just doing brachytherapy alone, right? That in and of itself is a little bit of a leap. And so I've gotten very confident in utilizing it completely in place of SRS because I see patients who have gone years now. I've used the technology for about 2.5 years, so I can't give you 4 or 5 year stuff, but there are obviously people who can. But for me, getting now beyond 2 years, I'm seeing some incredibly clean MRIs, and the patients who are succumbing to their disease is from systemic progression or systemic complications of the cancer, and not from CNS manifestations or regrowth. So it's pretty damn effective. Now, I could also broaden that and tell you beyond metastases that I've had a few, I think we've had 3 or 4 basically grade 2 multiply recurrent post-radiated meningiomas, and nothing really working for these. And I have a couple cases of some long-term survival. Again, we're talking about a couple of years here, but these are patients who were crippled by meningioma regrowth over very short periods of time. So I've been impressed with it in that setting as well. So yeah, I mean, I think that you know, for me, some of the things that I was concerned about going into, I thought that, well, you know, if I'm putting something like this in, you know, might there be more of a chance of a CSF leak because it's irritating the brain, or might there be a chance of a higher chance of wound infection? Just none of the above with that for me at all. Zero. Like these were some
Yeah.
of the things that I thought maybe going in. I think a lot of people may echo that stuff, but in reality, I don't even think about that now. I just I've not encountered any significant uptick in those kinds of complications using this.
Excellent. We do have a question from one of the attendees here that would like to ask the question. So, Benjamin, I'm going to open up the line. If you could introduce yourself and then ask your question, please. You might be on mute too, Benjamin. There you go.
No, I got you. Yeah, no, I got the thing is that I'm mute, so I got thanks for taking my question. So I'm a physicist at UCSF. I don't know. I apologize if you mentioned this, but I think and I'm not sure if I'm talking quite in the right study, but I think I saw that or say, I strike that from the record. Have you seen any seed migration? Because I thought that the benefit from tile over loose is it prevents those migrations. And I thought I saw a case of like a distant migration. And have you seen that? And then how would that be possible with the collagen matrix setup that the GammaTile had?
It's a great question. People have experienced it. I have not. In fact, I have a case I show where for meningioma with an enormous cavity, where, albeit on the surface of the brain, of course, but where the patient ended up having a traumatic subdural hematoma almost a year later into that cavity. And the seeds, you could see the seeds in place on the CT and MRI. And then I actually had to evacuate this. And I was able to see kind of how the collagen and the seed scarred into the brain surface with my own eyes a year out. I've not had to go in on many occasions. So I could say that you're right, that for the most part, the seeds don't migrate because the collagen tends to scar down on the brain surface. But there are times, depending on the cavity, where there can be, even if you've applied the tile to the brain surface, it can kind of fall back or flop back or whatever the case may be, because it's depending on the orientation and gravity and what have you, may not be up against the cavity as much as you'd think, or the wall, I should say. Or if you're putting another tile next to it, you may end up dislodging a little bit. So you have to kind of be cognizant of how you're laying the tile in. So I've not had a case of a significant migration personally, but I don't want to give you the false idea that it doesn't happen. It definitely happens, but it's infrequent. And there are ways to combat it in certain circumstances. There are times where you could fill the central aspect of the cavity with a dural sealant. We use things like, you mentioned you were a physicist, so we use things like Tisseal or Adherus or certain things that are absorbable that we'll use in other circumstances that can actually fill up the cavity and help to buttress the tile up against the wall. I used to use that a little bit more frequently. I don't know if it's the nature of the cavities that I've run into over the last year and a half, or just my comfort with applying it that I've used it less. So the bottom line is there are some intraoperative strategies to combat that. Even without those, it is infrequent. If it occurs, depends on kind of the severity of it. You know, I think if it's something dramatic in the immediate aftermath, you could consider going back in, but I don't know if anyone who's done that. I have to ask some of the other, people who have significant experience. But it really, it has the way the tile is physically structured. It allows for some error. There's some. The configuration is such that when you lay it along the cavity wall, the dosimetry works well. But even if it falls away a little bit, or even if it slips, or even if there's some migration, there's usually enough coverage that you're still safe. And I don't want to speak too much to that because that's more in the physics, radiation oncology sphere. but that's been my experience and understanding, not only with my own clinical experience, but being involved in a lot of these meetings and symposia, that it's quite forgiving the way it's been designed. So hopefully that answers some of your question.
No, that's great, and thank you very much.
All right, well, Dr. Hanft, we're at the top of the hour. I want to thank you for your time. I want to thank all those who joined for their time. If you do have any questions, you can just contact us through www.gammatile.com. There's a contact portion. And if you want more information on this too, and if you have any more questions for Dr. Hanft, you can contact us through the same link and we can forward it on to Dr. Hanft as well. So thank you all again for joining. Thank you again, Dr. Hanft, and we'll see you next month on our every third Thursday with GammaTile. Thank you so much.